Good afternoon, everyone. We're going to get started. I'd like to say thank you for attending the third session of our half-hour Hot Topic series. This series is brought to you by HealthInsight, the New Mexico Healthcare Association, and the New Mexico Department of Health. And it's basically designed to provide you a half an hour of great information that you can apply in your long-term care facility. So thank you for joining us. I'd like to take a moment to introduce our speaker for today. Jessica Mirabal is the Clinical Reimbursement Manager with Genesis Healthcare. She has 8 years of skilled nursing facility and long-term care experience in management positions and has worked as both a Director of Nursing and Assistant Director of Nursing. She's going to discuss the MDS coding for the Antipsychotic Quality Measure. We are delighted that she's willing to share her knowledge with all of you today. So without further ado, Jessica, we're going to turn this over to you.
Thank you, Shannon, and welcome everybody. Thank you for joining us for this half-hour education on MDS coding, the antipsychotic quality measure. One thing, as Shannon mentioned, my introduction, I've been in long-term care for about 8 years, and just recently 2 years as a clinical reimbursement manager, and it was with this experience that I learned more about the antipsychotic measure, quality measures in general, as well as how to work with them. And so I think it's an area of opportunity for everyone across the board. And so I was delighted to assist with this presentation. I hope upon the completion of this training, you guys will know the requirements for the RAI Manual of Coding Antipsychotic Medications, how the coding of antipsychotic medications affect your quality measure rating, and then give you some helpful tips on reducing and evaluating antipsychotics in your facility. And I think the first thing to keep in mind is your MDS and the coding of that MDS is what truly affects your quality measure rating. And I think the best way to discuss or to figure out the quality measure aspect is, let's get down to the basics. Let's look at how are we supposed to code section N for medications, and do we truly have an understanding of it? Because what I have found through my own practice and management is that we're not coding section N accurately, and that is causing us to have more residents trigger for this measure than is what is actual. So let's get down to the basics, section N. And so the intent of section N for medications is to code the number of days in which a resident received a certain medication during the last 7 days, and that's the look-back period for an MDS. Whether it's injection, insulin, or oral medications, we want to make sure that we're capturing that information. And one thing that recently came about with section N, these changes occurred in October, where they added the antipsychotic medication review. And this is to truly assist the facilities in evaluating the use and management of antipsychotics. And so I think it's an area that a lot of people are not very familiar with, related to this new edition of the MDS. And so it's a really good thing to look at, work with your MDS coordinators, and if they're getting any errors or warnings or related to that section, you guys should truly dig into that. And so fortunately, I won't be able to go into that aspect. I apologize. But we will, we will go into just the basics of the medication. So as you all know, medications are an integral part of care provided to the residents of nursing home. Residents taking these medications, they have side effects, and that can adversely affect their health, their safety, and their quality of life. We need to ensure that only medications that are required to treat the resident's condition are being used. It is important to assess the need to reduce these medications whenever possible and ensure that the medication is the most effective for the resident's assessed condition. We should also be looking at non-pharmacological approaches. I think that's also an area that we may be lacking in as providers is, you know, we know that there's medications out there, so that's naturally what we generally go to, but I think it's important for us as a team to not only educate our staff, but also our providers, our physicians about non-pharmacological approaches and trying those before we get to the medication aspect. So in order to code the MDS, we must review the resident's entire medical record for documentation that any of the medications that are listed in section N, if they were received in the past 7 days, that they're coded on the MDS. And we also should review documentation from other healthcare settings where they may have received medications. So as long as they're admitted to your facility, we should be coding those medications, even if they received them, say, at an outpatient appointment, or they went out to the ER and came back, we should be coding those medications. This is just a quick snapshot of what section N for coding medication looks like. And again, we have to indicate the number of days the resident received a medication by the pharmacological classification. And as you can see, the first one is your antipsychotic. So to code this section, you code the medication according to the pharmacological classification and not how they are being used. Antipsychotics, again, it's the number of days. Just because they may have received multiple doses within a certain day, you're only going to count that as 1 day. So generally, the max that you're going to be counting in there is 7 days. Medications that have more than one therapeutic category or pharmacological classification should be coded in those categories. So if you have, say, an antidepressant and an antipsychotic that are that is a dual medication, you should be coding in both of those questions. You, again, include any medication that is given to the resident by any route, so PO, IM, IV, and in any setting while they are a resident in the nursing home. You also count long-acting medications that are given every few weeks or months, only if they are given during the 7-day look-back period. And that was actually a question that I recently received from a building that I assist with. They were giving HALE IM, and I think it was every other week. And so I was asked, how do we code this? Well, you only code it if it was given within that 7-day look back period. So, you know, you have to take a look at your MARS and see, does it fall within? If it's, you know, day 8 of that look back period, of course, you won't be able to count it. So that is one thing that I think I see often when I'm doing quality measure reviews, is that we're not taking into consideration that entire look back period. Again, combination medications should be coded in all categories and pharmacological classes that constitute the combination. Doses of psychoactive medications differ in acute and long-term care settings. And we should always use the lowest possible dose to achieve the desired therapeutic effects. One thing that I have seen while being a director of nursing in a facility is getting those residents that maybe had some sort of delirium in the hospital, and just because they are of the elderly population, they are prescribed an antipsychotic, and then they come into the nursing home still on that antipsychotic, and there's no psychiatric background for this resident, and we just continue it on instead of looking towards reducing that. And I think that's one area of major opportunity across the board as providers, is looking at that practice. And, you know, when you get a resident in from the hospital who has no psychiatric background but yet is on a psychotropic medication, take a look at that, see if it's necessary, and work towards reducing it if at all possible. So a quick question, and if you guys want to use the chat box, that would be great. It's a true or false. Medications are coded based off the indication use of the medication and not the classification. I'll give you guys a few seconds to type in your answer. All right, looks like you guys were all paying attention. The overwhelming answer is false. And so you code the medication according to the therapeutic category and or pharmacological classification, not how it is used. And that is one thing I think that trips up a lot of providers when it comes to the quality measures and how they're coding their MDSs, is we may have a medication and it's used for, you know, let's say dementia or bipolar, and it is maybe an antidepressant. However, they're coding it as a antipsychotic. That's where we're triggering residents that we shouldn't necessarily trigger for this measure. So now that we know how to code the MDS for antipsychotics or medications in general, let's get into the quality measure aspect. And as of December of 2008, the 5-star quality rating system was added to Nursing Home Compare for all nursing homes participating in Medicare and Medicaid. The goal of this program is to provide residents, families, and consumers a way to compare nursing homes more easily and to help identify areas about which they may want to ask questions. The 5-star rating system features an overall rating of 1 to 5 stars based on facility performance for 3 types of measures, each with its own 5-star rating. So you have health inspections, staffing, and quality measures. And the quality measure ratings are based off of the MDS as well as claims-based measures. Again, your 5-star quality measure rating is based off the performance in 16 of the 24 QMs that are posted on Nursing Home Compare. Again, they're based off of MDS assessments, so the coding of them. Again, let's go back to Section N and making sure that we're coding that accurately, which ultimately affects this measure. And it is also based on hospital and ED claims. Those are your claims-based measures. The 5-star quality measures include 9 long stay and 7 short stay measures. The long stay measures include residents' ability to move independently has worsened. Residents who needs help with activities of daily living have increased. High-risk residents with pressure ulcers. Residents who have catheters inserted and left in the bladder. Residents who were physically restrained, urinary tract infections, self-report of moderate to severe pain, experiencing 1 or more falls with major injury, and our topic of today, residents who receive antipsychotic medications. Your short stay measures include residents whose physical function improves from admission to discharge, which that is our ultimate goal as providers, is, you know, let's get them to the prior level of function or even at a better level of function than maybe when they entered our facility. Pressure ulcers that are new or worsened, self-report of moderate to severe pain, and then again, our topic of today, residents who newly receive an antipsychotic medication. Your claims-based short stay measures include residents who were rehospitalized after a nursing home admission, percentage of short stay residents who had an outpatient ED visit, and percentage of short stay residents who were successfully discharged to the community. Again, we only include residents in a traditional Med-A covered stay for some of these measures. And some of these claims-based measures, which utilize the first MDS of this day for risk adjustments. So let's look at the percentage of residents who newly received an antipsychotic medication. This is our short stay measure. So you guys may be asking yourselves, what is a short stay? A short stay is defined as a resident whose latest episode is less than or equal to 100 days. So if they've been in your facility less than or 100 days, then they are going to trigger your short stay measure. And so the short stay measure, and there's a slight difference between the short stay and the long stay measure. The short stay measure looks at any resident who newly received an antipsychotic medication. And so this does not include the initial assessment when you're looking at the look-back scan. These are residents that came into your facility, did not have an antipsychotic upon admission, so it's not coded on that initial MDS, your admission. And then somewhere along the way, they got prescribed an antipsychotic. That's how this measure triggers. And so what I often see is that we may not have coded that initial MDS accurately. We may not have indicated that the resident was on an antipsychotic when they first came in, and then, you know, we get later into our assessment cycle, whether it's a PPS or an OBRA, and now they have an antipsychotic. So that's one area that you can look at. Take a look at your practice to see, are we accurately coding our MDS upon admission? Again, like I mentioned, residents that are excluded from this measure is if they had an antipsychotic coded on that first MDS, and it continued on. They will not be included in this measure. N0410A does not note specific antipsychotic medications. So just because a resident changes a brand or type of antipsychotic from MDS to MDS, like risperidol is changed to Abilify, it doesn't take that into consideration when doing this measure. All that the measure calculates or looks at is they were receiving an antipsychotic. There are some exclusions, and the exclusions are pretty across the board with both the long stay and short stay measure. The three diagnoses that will really help you with managing your measures are schizophrenia, Tourette's, and Huntington's. So take a look. That is one area that, again, that you can look at to see how can I affect my quality measures. If the resident has a history of any three of those diagnoses and say they didn't get onto your paperwork at your facility, work with your physicians to see, do any of these three apply? If they do, get those get that order for that diagnosis, enter it into your system, make sure that going forward it's coded on your MDS, and then from that point they will no longer be included in this measure. What I did here is I included a point range. This is for the antipsychotic measure. So what this is saying is if your facility is at 0% for antipsychotics use for residents who newly received it, you will receive 100 points towards your quality measures. And it goes down. If you're at 1%, it is gonna, or 100%, but even if you're at 1%, you get points deducted. So, you know, truly we don't want to see residents on antipsychotics or them to receive any newly added antipsychotics. So this is just a quick breakdown of where those points stand. The long stay measure, again, what is a long stay measure? Residents whose episode is greater than or equal to 101 days. So again, I mentioned a short stay measure is up to 100 days. A long stay measure takes over at 101 days. So that's how you can figure out where they're going to hit your quality measures. This measure looks at residents who receive just any antipsychotic. I think the best way that I describe this is, you know, we're given, say, 100 days to possibly reduce and eliminate that antipsychotic that maybe a resident came in on, or that we newly started. And then after 101 days, it's like, you know, what's going on? Why can't we get it reduced? Is this going to be a chronic medication? If this is going to be a chronic medication, that's when we need to look at our process and say, is it at the lowest dose possible? Have we tried other interventions? Again, the exclusions are the same for the most part, and the biggest ones are those diagnoses. The cut table for this is a little bit different than the short stay. You're given, what, about 6%? You can have up to 6% of your residents on an antipsychotic long stay measure and still receive the 100 points. And as you go through, you know, points get deducted, and this is done in increments of 20. So again, let's use your chat box feature. What question on the MDS triggers the antipsychotic quality measure? Is it the hypnotic, anti-anxiety, your antipsychotic, or both hypnotic and antipsychotic? So I think the majority of the answers are in, and you guys are right. It is C. It's just antipsychotics. It, you know, if it's a combination medication, you're going to code both, but it's still going to only trigger from your antipsychotic. The exclusions. What are the exclusions for the antipsychotic measure? Schizophrenia, Tourette's, and Huntington's, schizophrenia, Tourette's, or Alzheimer's, psychotic disorder other than schizophrenia, Tourette's, and Huntington's, or schizophrenia, post-traumatic stress disorder, and Huntington's. Looks like you guys are all doing an excellent job today. You guys are correct. It is A. Schizophrenia, Tourette's, and Huntington's are the exclusions for both short and long stay measures. So let's get into CASPER reporting. The one thing that, the reason I'm bringing this up is because I want you guys to go back and see if you have access to CASPER. This is a tool that is essential for helping you work your quality measures, essentially. And so, you know, get in touch with the key system, the QTSO, and get access. You can have up to 2 people. Generally, I recommend your MDS coordinator and maybe your administrator or your DON, that those 2 groups have access. So that way there is somebody that can pull these reports and look at them. And so once you do get CASPER access, what we generally pull is your MDS 3.0 QM reports, and what I actually pull is the package reports, which will pull your characteristics, your facility level, and your resident level quality measures in one click instead of having to go in and out. So it is a really, you know, it's really simple to actually pull once you get the access. All you have to do is just change your dates. So the timeframes that you're wanting to look at, one thing that we do is we look at them constantly. So I may look at them month over month. I may want to look at January through, we're in March now. I want to look at January and February just to make sure that there are no surprises on my quality measures. Because again, that can cue you into inaccurate coding of your MDS. So you'll put in your time frames, and then when you do get your CASPERs into your folders, this is your facility level. As you can see, there's some identifying information up here. You'll see your quality measures off to the left-hand side. thing to know with this is your numerator is the number of residents that actually trigger that measure. Your denominator is the number of residents that had the potential to trigger that measure. And the main percentage that you want to look at is this facility adjusted percentage. And if this percentage is greater than your state and national average, it's generally going to cause this bolded and asterisk number to happen. And when that happens, that means you're at the top of a percentile that you don't want to be at top of. So this is a good way to identify the quality measures that you want to tackle, because, you know, we know that it's not easy to tackle, let's say, 13, 14 quality measures and how to figure out which ones to look at. So this is kind of a good guide as to what you should target first. Then once you figure out your quality measures that you want to target, let's say it's the antipsychotic measure, you would come to your resident level quality measure report. And on here, it'll show you the residents that are grouped in this time frame. And then these X's right here under each quality measure across the top indicate the resident that, or the measure that is actually triggering for that resident. So as you can see, this resident has 4 measures that they are triggering. And one of them is the, what is that? Anti-anxiety and the hypnotic measure, and the antipsychotic, and behavioral symptoms. And another good thing to look at is this last column. It's the quality measure count. And if you see anything above a 2 or 3 here, those are probably the residents you want to target first, because they have a lot of measures that they're triggering for. And it's good to look at them. The best way that I explain this to facilities I work with is, you know, surveyors will come in and, you know, look at this and say, well, this resident is triggering for falls because they're on an antipsychotic and, say, a hypnotic medication, and they're on those medications because they have behaviors. And so those are the 4 areas that they are triggering per your CASPER report. And they will look at those areas and they will try and link everything together, and then that's how you get those piggybacking tags, as they call them. So again, this is how you utilize that resident level report. This is just a quick tool that I developed with my colleagues, and this is what we look at when we do an actual in-depth review of our quality measures. We look at the MDS, we look at how many days they received the antipsychotic, do any of those exclusions apply for that resident? What is their BIMS? What is their PHQ-9? That has an effect. If they have a low BIMS, you know, maybe we should look at other interventions than the medication. If they have a high PHQ-9, maybe they are showing depressive symptoms that we're treating with an antipsychotic and not the antidepressant. So, and then are they experiencing behaviors, and do we have that documentation of those behaviors? Maybe they are acting out because they're in pain and we're not adequately controlling their pain. And then, you know, if they are truly on an antipsychotic for an appropriate reason, then we go through and look to see, are we doing our GDRs? Are we monitoring the AIMS and any sort of psychotherapeutic medication evaluation? Are we doing that per our policies? Some tips for success that I have for you all is be proactive. Ensure that your MDSs are coded accurately prior to the submission. Evaluate your clinical processes that have an effect on your MDS coding. Ensure that antipsychotic medications are reduced to the lowest possible dose or eliminated if applicable. And work with your doctors on discontinuing antipsychotics prior to admission if no clinical history of a psychiatric disorder. Be reactive. Evaluate your CASPER reports monthly for accuracy and modify MDSs if applicable. If your MDSs aren't coded correctly, then, you know, make that correction. Identify, again, your clinical processes that need to be improved for better resident outcomes. Ensure that interval monitoring of the antipsychotics is completed as appropriate. And again, keep focus on the end goal, and that is quality care. A 5-star QM and excellent survey outcomes derived from providing quality care. I want to thank you all for joining today. I have included myself, my counterpart, Debbie Coble-White, as well as Tina Sanchez, who is the state's MDS coordinator, contact information. So feel free to reach out to us.
Okay. Well, thank you very much, Jessica. This was great. One question we had a little bit earlier in the presentation, which I think you started to touch on, is if a resident goes to the emergency room during the look-back period, do we need to code the MDS for medications the resident received in the ER?
Yes. Yes, you do.
Okay. Great. Thank you for that. And then Rebecca Taylor asks if they could get a copy of this presentation. I had mentioned to Rebecca that we are recording and posting this webinar, but certainly in terms of if people wanted a hard copy, what would be the best way for folks to go about?
They can reach out to me, I guess, and I'll put my email address into the chat box, and I don't mind sending it to them.
Great. Okay. Again, on behalf of the New Mexico Healthcare Association, the New Mexico Department of Health, and HealthInsight, I'd like to thank you for attending our training today, and would especially like to say thank you to Jessica Mirabal, who, again, did a phenomenal job, and we greatly appreciate her sharing her expertise. So thank you, Jessica.